um, distract a little from GI prophylaxis. I am an associate professor at the College of Pharmacy for UH Hilo. And today I'm going to give a presentation, just a pharmacist perspective. I am a critical pharmacist by training. So just pharmacist perspective on the vent bundles. I know a lot of you are nurses and respiratory therapists, correct? So we know what vent bundles incorporate, and there's been some new evidence and new literature to support what we do as far as best practices and whatnot. So basically, I'm just going to go over more pharmacotherapy with the pharmacist perspective. I have no conflicts of interest. And then I would just want to test this out. Do have some audience participation in here. And then for those of you online, you can just scan the QR code and see if that works out. Last time it didn't work out so great, but we'll see how it goes. And the question is, do you have a standard ventilator bundle or order set that you utilize at your institution? What is working? Okay, so hopefully that's a kind of a test question. So to test out this software. So it looks like most of you do have a bundle or order set that is utilized. Some places do not. I know we put it together piecemeal, or some of the practitioners or providers have to put it in individually. So just to go over some of the vent bundle inclusion or what's in your ventilator bundle. Let's see if this is going to start. This might not work. We'll see. You know if this one's working, but I'm not sure. So the question I think here was, which of the following are part of your ventilator order set? I'm not sure this one's working so well, so I apologize. So the options, if you look at the QR code, it should be chlorhexidine, stress ulcer prophylaxis, artificial tears. So think about what you have within your order sets and how often you utilize them. And we'll go over for the rest of this presentation if things should be changed, maybe at the institution level or practice level. Wait. That jumped ahead. I apologize. So why bundles? So what are care bundles? I think Jessica went over some of the care bundles yesterday. We use a lot of these care bundles in the critical care settings just to improve consistency in delivery of care. These are basically evidence-based best practices that are grouped together to assure efficient and timely care and improve patient care overall. The bundle I'm going to talk about is the ventilator bundles. So these bundles were created due to increased mortality, morbidity, things like hospital length of stay ventilator days associated with ventilator-associated pneumonia. So a lot of these strategies were created to prioritize prevention of ventilator-associated pneumonia or ventilator-associated events. They also include in the newly updated literature, this term called non-ventilator hospital-acquired pneumonia. So these are patients who are not actually on ventilators, so the non-invasive ventilation modes as well. There has been a long evolution of these preventative strategies. This is just a timeline of events as far as ventilator bundles and strategies. In 2004, the Institute of Healthcare Improvement put out this statement or a set of recommendations to include these 4 elements into your ventilator bundles. Those are elevating your head of bed. We do this every single day for all of our patients, right? You have daily spontaneous awake trials or spontaneous breathing trials coordinated together. Then we have our favorite stress ulcer prophylaxis, and then DVT or venous thromboembolism prophylaxis. And then later on in 2008, the Society for Healthcare and Epidemiology, along with the Infectious Disease Society of America, they put out some practice recommendations that looked at implementing and prioritizing strategies to prevent ventilator-associated pneumonia. Then later on in 2010, an additional point for the ventilator bundle was made, and that was daily oral care with chlorhexidine, or CHG is what most of you know it as. And that's like the toothbrushing and the swabs with CHG every morning or twice a day. Then in 2014, there was an update to some of the recommendations for with IDSA and Cherie. Basically, they just changed or reclassified some of their recommendations, and they made basic practices, special approaches, and then they retermed some of the terminology and recommendations to not recommended or generally not recommended. Later on in 2016, ICS, or the Intensive Care Society, actually put out a set of recommendations too. It kind of mirrors what happened in the past, where again, you have an elevation of your head of bed, you have your SATs and SBTs coordinated together, and this kind of like mirrored the pain, agitation, delirium guidelines as well, what they recommended with the bundles and ABCDF bundles as well. There's recommendations on subglottic secretion drainage, avoiding direct or scheduled ventilator circuit changes. Then they recommended to take oral chlorhexidine out as your oral hygiene for this recommendation. And then they changed some of the recommendations for stress ulcer prophylaxis to only those at high risk. And we'll go over that with some of the literature and updated recommendations put out with Society of Critical Care Medicine and the American Society of Hospital Pharmacists as well. And then the most latest update for ventilator bundles was in 2022. Cherie, IDSA, and the APIC committees, they put out other practice recommendations that, again, it just recategorized a lot of essential practices, additional approaches, and things that are not recommended. So here are some of the recommendations. So these essential practices are things that should be adopted by within practice. And then you have this term here, additional approaches. These additional approaches were made for facilities where control of hospital-acquired infections was not adequate enough with the essential practices. So they added on these practices for those who are having difficulties with their ventilator-associated pneumonia or ventilator event rates. So some of the essential practices where you kind of know all of this if you're a practitioner, like high flow nasal oxygen or NPPV. You want to avoid intubation if possible. Then you have your SATs, your spontaneous awake trials, minimize sedation to very, very light, just what is needed or necessary for your patient. Toothbrushing without chlorhexidine. I am not a pediatric specialist, and I think we have one here, so I'm just going to say caffeine therapy for preterm neonate extubation. I'm not entirely versed on that, but we do have some pediatric specialists that could possibly answer that question. Some of your additional approaches are things like your subglottic secretion drainage, early tracheostomy if possible, post-pyloric feeding, so making sure your patients get fed and you advance that feeding to decrease rates of aspiration. Things that are not recommended now are going to be your chlorhexidine, your probiotic administration, specialized ET tubes or endotracheal cuffs, and frequent cuff pressure monitoring. Those kinds of things are not recommended anymore. And then there's this new addition of prevention for non-ventilator hospital-acquired pneumonia. So from my perspective, as far as these ventilator bundles go, I'm looking at sedation and analgesia, stress ulcer prophylaxis, and oral care. The VTE prophylaxis or venous thromboembolism prophylaxis, that's part of your daily care within any acute medicine or hospital type patient. I'm not going to spend a whole lot of time going over this because I want to focus more on those ventilated patients. So this is something that all hospital pharmacists or specifically critical care pharmacists look at daily. This is our checklist. This was created by Vincent and colleagues way back in the early 2000s. It's our checklist basically to look over an ICU or critical care patient, and it incorporates a lot of these different ventilator bundles and prevention strategies. So there's a mnemonic for it. It's called Fast Hugs VID. These are our key elements. It incorporates a lot of the ABCDF bundle for pain, agitation, delirium, and sedation. And then it also incorporates some of these ventilator strategies as well. So things like analgesia sedation, which I'll go over, the head of bed elevation, stress ulcer prophylaxis, your SBTs, SATs, looking at de-escalation of antibiotics, bowel regimens, removing catheters, and anything that is unnecessary for patients at that time. So looking at one of the first parts of key elements and of the ventilator bundle strategies, it's sedation and analgesia. So I'm not going to spend a whole lot of time because this could go on for hours talking about sedation and analgesia. There's a brand new guideline that just came out a few months ago in March by Society of Critical Care Medicine. It is a focused update, so they didn't rewrite the whole guideline. They just updated the 2018 guideline. Some of the updates within that guideline are going to be that instead of suggesting propofol or dexmedetomidine over benzodiazepine, they made this comment about dexmedetomidine is preferred. So dexmedetomidine is otherwise known as Precedex, if you didn't, just so you can put those two together. So they're suggesting Precedex or dexmedetomidine over propofol. This is a conditional recommendation. We kind of all knew this before, like the dexmedetomidine to get the lighter sedation levels, get them extubated faster. We were doing this before, but your pharmacists or pharmacy departments are probably like, this is such an expensive drug, we don't want you to use it, so I want you to use propofol instead. But now it's not as costly, and Precedex or dexmedetomidine is, they are recommending to try to use that over the propofol instead. Prior to that, they just suggested, you could use propofol or dexmedetomidine as long as you try to avoid the benzodiazepines. Okay? And we still want to try to avoid benzodiazepines if at all possible as well. Okay, and this is not going to work, but it was another question on stress ulcer prophylaxis. So we'll skip that. So now we're going to move into EHUB's favorite topic, which is GI prophylaxis or stress ulcer prophylaxis. So I call it the great debate. There has been so much literature that has just recently come out. Before 2020, there was basically one article or one paper that we were all looking at, and it's a 1999 article. This was what we were using as pharmacists to guide our practices. And basically this paper said, use stress ulcer prophylaxis in patients who are mechanically ventilated for 48 hours or more. That was like one of the risk factors. Fast forward 20 years or so, and now we have newer guidelines that recommend or that have been looking at stress ulcer prophylaxis a little bit more in depth, looking at adverse effects associated with use or clinically important bleeding or the decreased amount of clinically important bleeding using stress ulcer prophylaxis in mechanically ventilated patients. So I just put here some of the articles that have popped up and the literature regarding stress ulcer prophylaxis. The newest one is going to be this 2024 update released by Society of Critical Care Medicine in cohort with the American Pharmacists Association. So a lot of these recommendations come from those papers, more the updated ones. The first, which is one of the stronger recommendations, is you can use enteral nutrition to reduce clinically important stress ulcer-related bleeding. So feed your patients early as soon as possible. This helps decrease risk of stress ulcers. The next set of recommendations is that they identified risk factors for clinically important bleeding. And these risk factors, if your patient has these, they do suggest that stress ulcer prophylaxis would be indicated in those patients. So those are things like coagulopathy. So if you have low platelet count, less than 50, you have an elevated INR, your prothrombin time is also elevated or extended as well. Things like chronic liver disease, so that includes a history of cirrhosis, portal hypertension, hepatic encephalopathy. Those patients who have shock or who are admitted with shock. This neurocritical care patients is kind of its own little realm. They study neurocritical care patients in a separate set of studies, but it is recommended to start GI prophylaxis in those specific type of patients. They also suggest that stress ulcer prophylaxis is used to prevent clinically important upper GI bleed in those who are enterally fed, so if you're feeding them, and they have risk factors. If they do not have risk factors, it is not necessary that you need stress ulcer prophylaxis in those patients. So, is mechanical ventilation, so the question of the hour, is mechanical ventilation a risk factor? So there is this meta-analysis and study put out by Granholm and colleagues, and it's kind of supported by literature by McLaren and colleagues back in Granholm and colleagues support the evidence in these studies supported the recommendations for the updated guidelines, the 2024 critical care guidelines. So this meta-analysis showed that predictors of clinically important GI bleeding. So clinically important GI bleeding is defined as overt GI bleed with hemodynamic compromise, the need for transfusions, and a decreased hemoglobin. So that's what they considered as clinically important bleeding. So they identified that the risk factors for increased clinically important bleeding were those that I just stated earlier: coagulopathies, shock, liver disease. They also found that mechanical ventilators' effect on clinically important bleeding was non-statistically significant. So the takeaway from this is that mechanical ventilation is not a risk, likely not a risk factor for clinically important upper GI bleeding. And Ehab loves that I said that right now. It is not a risk factor, but dun, 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 here's your debate. Right after those guidelines were published, this paper came out in the New England Journal of Medicine. This paper by Cook and colleagues looked at stress ulcer prophylaxis during mechanical ventilation specifically. And this is right after the guidelines, so this did not affect what the recommendations in the guidelines were. So this paper, basically it looked at the use of pantoprazole, which is a PPI, versus placebo in patients who are mechanically intubated, and looked at outcomes like clinically important GI bleeding and death from any cause or all-cause mortality at 90 days. The clinically important GI bleeding was statistically significantly less in the PPI group or pantoprazole group. And again, their definition of clinically important GI bleeding is, again, GI bleed or overt GI bleed, needing hemodynamic support or therapeutic interventions. They also did not show, the caveat here, they did not show that it affected mortality at all. So no mortality benefit, but did decrease need for transfusions and those clinically overt types of bleeds. What is interesting with this study, though, is that they did have some tertiary outcomes that they looked at. And these tertiary outcomes were things like causality of ventilator-associated pneumonia, Clostridium difficile, or Clostridioides difficile, like the effect that it has, because historically we all think GI prophylaxis is going to cause pneumonia in my patients, higher risk of ventilator-associated pneumonia or aspiration pneumonia. This kind of said it does not do that, and a lot of the other literature that has come out supports that as well. It is not associated with an increased risk of Clostridioides difficile. Basically no effect on mortality, but there was an effect of patient-important upper GI bleed, which I have defined as they need a single transfusion, they need vasopressors, they need a CT or diagnostic endoscopy, things like that. So those are patient-specific factors that it did make a little bit of a difference on. Again, these are secondary outcomes, so not something that this study was powered to look at. Okay, so perspective-wise, it is you, the provider. It's your decision what you want to do with your stress ulcer prophylaxis. Use it, lose it. My perspective is I can go either way. The literature supports either, and it's so gray right now. You can go either way. But what I am looking at as a pharmacist is if you're going to start it, I'm going to reassess the need every single day. And I'm going to ask you, do you still need this? Can we transition to oral from IV? Can we get rid of it upon discharge to the ICU? Looking at what type of stress ulcer prophylaxis, it is preferred to use a PPI, proton pump inhibitor, like your pantoprazole versus your H2RA. That's like your famotidine or Pepcid. There is no pneumonia risk and no risk for Clostridioides difficile. So if you come to me saying, okay, no, I'm so worried about these things, like it's not an associated risk factor. So I'm going to tell you, don't worry about that. Okay, and then hopefully, I guess this one works. Moving on to a different topic for oral care. So this is another controversial topic that we've been going back and forth with. So oral care, do you use it in your mechanically ventilated patients? What types? Do you use toothbrushing with CHG or chlorhexidine? Do you not do oral care, or do you just do regular toothbrushing? Okay, so for a little bit of saving time for questions, it looks like we're still doing CHG or chlorhexidine with toothbrushing versus just toothbrushing alone. So the Institute for Healthcare, their ventilator bundle, again, I said, included daily oral care with chlorhexidine. Since then, a lot of meta-analyses and studies have been put out there. And these include all these randomized double-blinded controlled trials, and they've been looking at the impact of oral care with chlorhexidine on ventilator-associated pneumonia rates, mechanical ventilation, ICU length of stay. And there is another paper that kind of says it may be associated with higher mortality rates. So a lot of facilities are taking it off of their order sets, and we are not using it as much. We're just using regular toothbrushing without the CHG. So a lot of these studies, meta-analysis, looked at association of this mortality. There's just one paper in 2014 by Klompus and colleagues. It looked at use of chlorhexidine in cardiac surgical patients and non-cardiac surgical patients. And it just showed, it's really interesting here because it showed that there was an association with higher mortality in non-cardiac surgical patients. So for those who are undergoing cardiac surgery, it still might be a good recommendation until literature proves it wrong to still be using the CHG or chlorhexidine oral care for those types of patients. Why they did it that way, I don't really understand why they looked at the two separate populations, but it did show an association with higher mortality. So moving on, fast forward to 2022, here we are. It says the recommendations are to not use the chlorhexidine anymore. So we at Ventus Health, they just updated the care bundle and they took that chlorhexidine out of there. So I no longer have to verify that chlorhexidine order, which makes me happy, and it decreases my workload a little bit, just a little. So my perspective, less is more. Stress also prophylaxis, less is more. Sedation, less is more. Sometimes you have those patients that actually kind of do need more, but less is more usually. And then the CHG mouthwash, of course, try not to use it, just do oral care with normal toothbrushing. Again, less is more. And that concludes my talk. Hopefully I educated you a little bit about some drugs and literature.